Dr. Kamen, you mentioned earlier about not being happy with where we are in PH treatment, but I guess you're happy about the options that are available now in medication. Let's talk about those and how they impact the patient.
Yes, we now have 14 medications that are approved by the FDA to treat pulmonary arterial hypertension. When I started working in this disease state 18 years ago, we only had one, which was called Flolan, and had a lot of challenges associated with it. And so it has been such a great experience to have been a part of seeing all these treatments come to market over the last 2 decades. So things have really gotten a lot better. As I'd mentioned before, we still don't have a cure, so we're not done yet, but we do have a lot of options. In some ways, it's made the treatment challenges a little bit more difficult because when we only had one or two, it was pretty easy to talk to patients about what we would recommend. Now we have 14 medications, so that the conversation can be a little bit longer and more detailed. But certainly things have gotten much better for patients with this disease.
Where are the conversations going with patients in terms of major concerns and issues?
Yeah, so we have to always keep in mind what is going to work for the individual patient. For example, some of our IV therapies require that patients have what we call a mixing partner, somebody that's trained on how to mix the medication because they do that at home, how to operate the infusion pump. So they do have to have a level of social support in order to be successful with some of these therapies. So those things are important. Also, it's important to understand or prescribe medications that the particular physicians or providers have experience with. So, as people out in the community are prescribing medications, it's important that they have that level of expertise before they start providing, IV therapies and things like that. There's also, of course, there's always cost issues and insurance issues and challenges that we do work through on a daily basis as well. The prostacyclin medications, of course, are most challenging to administer for the patients. But they're also the best medications that we have for the patients who are more advanced in their disease, or what we would say are the sickest patients. The prostacyclins are the gold standard for those patients. And unfortunately, they haven't always been available in an oral form until recently. But still, the IV therapies are the strongest or the best medications for these patients. I mentioned that we have 14 medications now approved by the FDA, and they fall into what we call pathways. There's 4 pathways. And one of the pathways is called the endothelin receptor antagonist pathway. Those medications work by blocking a substance called endothelin, which naturally causes blood vessels to constrict. So these medications block the effect of endothelin to keep pulmonary arteries open. We have 3 of those approved by the FDA. Then there's the nitric oxide pathway. Those are what we call PDE5 inhibitors, more commonly used by men for erectile dysfunction. We use those to treat pulmonary hypertension. And then we have the prostacyclin pathway, as I've mentioned, being the strongest, most efficacious treatments that we have, but also carry the most challenges. And then more recently, there's a medication approved that's an oral form. It's a prostacyclin receptor agonist, not specifically a prostacyclin, but it's a pill that provides some prostacyclin-like effects.
So there's a number of factors that you have to consider when initiating therapy. Could you discuss those?
Yes. The standard now for almost all patients is to start on 2 therapies, what we call upfront combination therapy. So we'll choose, in most cases, an ERA, an endothelin receptor antagonist, and a PDE5 inhibitor, or a soluble guanylate cyclase stimulator, one or the other. And patients then will be on 2 therapies, and we'll see how they do. And if they are not meeting goals or progressing, then we'll add a prostacyclin. That's, I would say, the majority of patients. But if we first meet a patient who's very, very sick, then we would start right out of the gate with a prostacyclin. So looking at disease severity is certainly very important when we make treatment decisions. There's also some potential drug-drug interactions, a couple of our medications. For example, PDE5 inhibitors. Patients can't be taking any form of nitrates, so we have to think about that. If they're on a nitrate, do they really need it? Maybe we can stop it. But there's just a few drug interactions that we have to keep in mind, and some other comorbid conditions that we think about too when we're making treatment decisions. But I would say the most common one is just really looking at disease severity. when we make decisions.
Thank you very much, Dr. Kimber.
You're welcome. Thank you.